Good morning everyone, myself Dr. Kirti, Assistant Professor, Physiotherapy Department. So today we'll discuss about knee deviations. So basically during initial contact or heel strike, there would be excessive knee flexion which could be due to spastic knee or flaccid quads. Then during the foot flat, deviation could be geno-recovatum which could be due to flaccid or weak quads or soleus. During mid-stance also geno-recovator which could be again due to flaccid or weak quads or soleus or could be spastic quads. In the push-off phase, there could be excessive knee flexion where the center of gravity is forward or we can say in front of pelvis. So there could be limited knee flexion which could be due to spastic or overactive quads or plantar flexors. In the acceleration to mid-swing, there could be excessive knee flexion which could be due to diminished pre-swing knee flexor withdrawal reflex, or limited knee flexion in which there is pain in knee, diminished range of motion in knee or extensor spasticity. So knee flexor contracture, the abnormality is pronounced with rapid walking as absence of full knee extension, shortens the leg giving rise to short leg length. So there is mild reduction in contralateral step length. So as the contracture progress to 20-30 degree, then there is lack of mid stance, knee extension becomes obvious, and with increased severity it is difficult to advance the ground reaction force vector anterior to knee. And in normal mid stance position, it increases the muscle imbalance based on the quadriceps to maintain the weight bearing to flex knee. Forward trunk leaning is used by some patients to lessen the quad demand, and compensatory hip flexion, ankle dorsiflexion, which also increases quadricep weakness. Normally during heel strike, the quads normally centrically contract to control the limb loading and prevent excessive knee flexion, and with mild to moderate weakness, knee is extended at or prior to heel strike, or we can say knee flexion is eliminated. So when normal plantar flexor or extensor strength at hip is present, usually the extension at knee maintained by the use of the hip extensor and increased plantar flexor activity. So when the center of pressure move forward or shift forward, the ground reaction line also move front of the knee. With more weakness, there is likelihood of instability and collapse increases. Also, which include forward trunk leaning, recovatum development, and use of upper extremity to assist in knee extension. So next we are having the bow leg gait, which is known as genovarum gait. Knee faces outward due to increased physiological valgus of knee, and legs will be in the board position. And quadriceps gait, in this quadricep action is needed during heel strike and foot flat, and weakness or paralysis will lead to buckling of knee during it, and there could be loss of balance. So patient compensate this by if he or she is having the normal hip extensor and plantar flexors. So with compensation, quadricep weakness, the individual lean forward in the early stance phase. Normally the line of force is behind the knee, which requires the quadricep action to keep the knee buckling. So by leaning forward at hip, COG is shifted forward, and now the line of force falls in front of the knee, so it leads to knee backward into extension. So another compensation is use of hip extensors, like as shown in this figure, and hip extensor and ankle plantar flexors to pull the knee in to extension. In addition, the person may physically push on the anterior thigh, holding the knee in extension. Last, we are having the geno-recovatum. In this, the quads are weak, and during stance phase, knee will go into hyperextension, and during the terminal swing, without hamstring to slow down the swing forward of the lower leg, the knee will snap into extension. Thank you.